Welcome to Essentials of Acute Care. I'm Dr. Sunil Garg. In my last two videos, I discussed about antimicrobial resistant organism and antibiotic selection, where I discussed about ESBL organism and MPC beta-lactamase producing organism. In this video, I'm going to discuss about antibiotic selection for CRE or carbapenem resistant enterobacterales. In the last part of this video, I will be presenting few cases with you so you can apply newly acquired knowledge for the decision making at the bedside or for attempting questions in the examination. Carbapenem resistant enterobacterales or CRE by definition are refers to organisms displaying resistance to either meropenem or imipenem or isolate producing carbapenemase enzyme. Here it is important to note that ertapenem, which is a carbapenem, not included in this definition. It comprises a heterogeneous group of pathogens encompassing multiple mechanisms of resistance. Broadly speaking, one is through production of carbapenemase and other is where carbapenemase is not produced. Common carbapenemase include non-metallobeta-lactamase or metallobeta-lactamase. With regards to non-metallobeta-lactamase, it includes KPC or Klebsiella pneumoniae carbapenemase and another is OXA or oxacelinase. Here it is important to understand that KPC is not restricted to Klebsiella pneumoniae only. With regards to metallobeta-lactamase, it includes VIM or Verona integron, IMP or imipenem hydrolyzing, and NDM or New Delhi metallobeta-lactamase. From the treatment perspective, it is important to understand if there is infection with CRE. It is important to know whether organism is a carbapenemase producer or not, and if they are carbapenemase producer, then which carbapenemase organism are producing. Regarding treatment of various carbapenemase, ceftazidime avibactam has activity against KPC and oxapoti. Meropenem, vaporbactam and imipenem/statin-relibactam has activity against CRE infection that produce KPC and not against any other carbapenemase. There is no activity of ceftazidime avibactam, meropenem, vaporbactam and imipenem/statin-relibactam against metallo-beta-lactamase producing CRE, but these three antibiotics works against CRE that do not produce carbapenemase. It is important to note that metallo-beta-lactamase cannot hydrolyze aztreonam, so aztreonam is used or effective against infection with the MBL organism. Sapidurocol has activity against all CRE infections irrespective of whether they produce carbapenemase or not, and if they produce carbapenemase, which carbapenemase. To preserve activity of cefiderocol, as there are limited therapeutic options against metallo-beta-lactamase, it is used as alternative treatment option for non-urinary CRE infection which are non-metallo-beta-lactamase producer. In the management of CRE infection causing complicated UTI or pyelonephritis, non-beta-lactam antibiotics like trimethoprim, sulfamethoxazole or quinolones can be used as preferred therapy if organism is sensitive. Though the likelihood of susceptibility to these antibiotics is low, other preferred therapy for such infection include ceftazidime avibactam, meropenem vaporbactam, imipenem/statin-relibactam, and cefiderocol. When carbapenemase testing results are not available or they are negative, ceftazidime avibactam, meropenem vaporbactam, and imipenem/statin-relibactam can be used for the CRE infection outside the urinary tract. For the treatment of the infection outside the urinary tract and possibility of metallo-beta-lactamase is high based on the previous sensitivity data or resident of a region with a high prevalence of such infection, the combination of ceftazidime avibactam and aztreonam or cefiderocol as a monotherapy is used while awaiting the antibiotic sensitivity result to novel beta-lactam agents and carbapenemase testing results. Tigecycline or ervacycline can be used as an alternative treatment option for CRE infection outside blood and the urinary tract. and its activity is independent of the presence and type of the carbapenemase. For the non-urinary infection due to CRE KPC, the treatment is meropenem vaborbactam, ceftazidime avibactam, and imipenem/statin ralibactam. In such patient, cefiderocol is an alternative treatment option. For the treatment of CRE, OXA48 infection and that is outside the urinary tract, the treatment is only ceftazidime avibactam and cefiderocol is an alternative treatment option. As we know, for the OXA, meropenem vaborbactam and imipenem/statin ralibactam does not work. For the CRE infection which is outside the urinary tract and it is because of the metallo-beta-lactamase and it includes NDM, VIM and IMP, the ceftazidime avibactam in combination with astronam or cefiderocol as monotherapy is given. NDM is New Delhi metallo-beta-lactamase. Though astronam cannot be hydrolyzed by metallo-beta-lactamase, it can be hydrolyzed by other enzymes like ESBL, MPC beta-lactamase, KPC or OXA, which are frequently produced by organisms which produce MBL. Avibactam takes care of these other enzymes which can hydrolyze astronam. And this is the reason that astronam is given in combination with avibactam for CRE infection that produce metallo-beta-lactamase carbapenemase. If cefiderocol as a monotherapy or combination therapy with ceftazidime avibactam and astronam is not possible because of allergy, intoxication or intolerance, the combination therapy with astronam and meropenem vaborbactam or imipenem/statin ralibactam can be considered, provided OXA type carbapenemase are not present. Since meropenem vaborbactam and imipenem/statin ralibactam are not effective against OXA type carbapenemase. With regards to other antibiotic, polymyxin B and colistin, they are not suggested for the treatment of infection caused by the CRE infection, except colistin, which can be used as an alternative therapy for cystitis. The role of combination antibiotic therapy means the use of beta-lactam agent in combination with amino glucoside, fluoroquinolone, tetracycline or polymyxin is not suggested for the treatment of infection caused by the CRE infection. There is only single role of combination therapy and that is combination of ceftazidime avibactam in combination with astronam for the metallo-beta-lactamase producing organism. Here you can pause and read the question for yourself. Here you pause and read the choices for yourself. This is question 2. Here you pause and read the question for yourself. Here you pause and read the choices. This is question number 3. Please read the question for yourself. Question number 4. Please read the question for yourself. Please read the choices for question number 4. Please write down your answers in the comment section box where I will respond. Once again, thanks for watching this video.